Good afternoon, everyone, and thank you for joining us to in this policy forum that's sponsored by the Lung Health Foundation, and we'll be tackling the issues of inequity in lung cancer outcomes. I'm happy to welcome you today. My name is Avis Favreau, and I work for CTV National News. I just recently semi-retired, but I'm happy to welcome some panelists where we will be discussing lung cancer. Now, people think that lung cancer is an equitably measured illness that's out in the community, but there in fact are a lot of differences, and scientists are learning a lot about who's at risk, who should be screened, who isn't being screened, and how we need to make things better. So welcome to everyone, and I'd like to introduce you to our panelists today. First, from Ottawa is Jackie Manthorn, who is President and CEO of the Canadian Cancer Survivor Network. We're also joined in Toronto by Dr. Ambreen Sayani, an adjunct professor of health policy. She also is a researcher at Women's College Hospital. And from Australia, via Hamilton, Ontario, Dr. Christian Finley, who is a thoracic surgeon and also a lung cancer specialist who's very well, involved in screening and trying to make things better for lung cancer patients. And so we'll be discussing this today. Now, what I'd like to bring forward is why this is important. So I was taking a look at some of the statistics about lung cancer, and this is a very big problem in Canada. Among the statistics, there are 21,000 people in Canada diagnosed and who die of lung cancer each year, making this 1/4 of all cancer deaths in the country. It means it is a huge problem. When you look at it on a daily level, on average, some 85 people are diagnosed with cancer in Canada every day, and also some 51 of these patients die each year. I think there's another slide coming up. That's right, 58 Canadians will die from lung cancer every single day, an idea of how big a problem it is. When we look at the causes of lung cancer, 72% of lung cancer cases are due to smoking. There's a subset caused by secondhand smoke. Then there is radon, which is, we're growing in awareness of what that problem is, along with asbestos, occupational exposure from chemicals in workplaces, and a growing awareness of air pollution and its role on triggering lung cancer in people. So that's a new problem that they're looking at. And so how do we tackle this? Because the 5-year survival on average is 19%, depending on the type of lung cancer that's diagnosed and at what stage it's diagnosed. So among the developments in the last few years has been the idea of screening using CT scans. And the Canadian Task Force on Preventive Healthcare recommends screening for lung cancer with a low-dose CT scan once each year for 3 years for people at high risk, those 50 to 74 years of age and are current or former smokers, and they've smoked a pack a day for at least 30 years or 2 packs a day for 15 years. And screening, we see from studies, prevent a lot of deaths because the cancers are caught early when they're treated. So we'd like to begin this policy forum by first going to Dr. Christian Finley, who as a doctor is on the front lines of what is going on. He sees patients, and his group in Hamilton deals with some 3,000 cases a year, if I'm correct, Dr. Finley. So I'm just wondering if maybe we can start off with you about what you're seeing and the inequities that you're seeing.
Yeah, I think thank you very much for that introduction and really framing it well for the audience. Lung cancer kills more people than colon, breast, and prostate combined. And certainly when we talk about cancer, those are the big four. And the fact that lung cancer represents so much more death than all the other ones combined, it really speaks to what a big problem it is. But because it's such a socially stigmatized disease with its associations with smoking, it gets only about 10% of the funding for research that any one of those diseases gets. So even when you talk about the funding for research, there's inequities. But when we look at the people who are suffering from this disease, I work at CPAC, and in that role, we put out a report on inequities in lung cancer and found that people who are impoverished, who are in the lowest bracket of income, have about a 25% increased chance of dying of lung cancer. They're more likely to get lung cancer, and even those that have low stage lung cancer that is curable, they're more likely to die of it. So it really is an incredibly unequal distribution of the disease, but also in how we treat people. Those that are poorer, that live in more rural and remote settings, that are recent immigrants, face so many barriers to getting curative intent therapy that they can't overcome all the barriers against them. I work in a lot of socially disadvantaged areas, Brantford, down in the Niagara Peninsula, and people even struggle to get to appointments because when we plotted it out from your first contact with your doctor to your first to completion of treatment, it's usually about 12 trips into the hospital. And for some people, that's just more than they can do if in the depths of winter for a 75-year-old or 80-year-old with other medical problems, or we've had patients who haven't sought curative therapy for themselves because they're taking care of their spouse and they're the primary caregiver and they can't find anyone to take care of them. So this is a disease that deserves our attention and our respect. There's a lot of great innovative policies out there, but not the least of which I think the first step down that road is lung cancer screening. That lung cancer screening represents a 20% improvement in survival just with that one intervention. And if you got to think that if we found something that had a 20% improvement in survival in children, that we would have funded it yesterday, that everybody would have access to that. But because we're talking about lung cancer and people stigmatize that disease, it still really isn't prime time in our country. And CPAC, again, has put a lot of time and effort and money into getting lung cancer screening across our country. And I know the Lung Health Foundation is a real partner there. We need to really put our shoulders behind it and push. So.
Right. So, Dr. Finley, when you see patients, how often do you see them early enough to be treated, or are you seeing more in later stages that makes it more difficult for them to have a good outcome?
Yeah, 18% of lung cancer patients diagnosed in Canada get surgery, which is the only way you're going to get cured of this. A small proportion with radiation, but the majority of surgery that does the heavy lifting for cure, and only 18%. And I've had when people have had symptoms for a year often when they come in to see us. And this is one of those diseases that if you're presenting symptomatic, often it's too late to it's in the later stages, which means that your opportunity to cure is very low.
And from your patients, do you see certain trends in terms of racial backgrounds, in terms of income? Where do you see the weight of the burden of this disease going?
Yeah, you're right that it's disproportionately distributed on racialized minorities, lower income, geography is also comes to play. People that live in rural and remote areas, all of those groups suffer from more smoking, and unfortunately also suffer from more burden of disease.
Hmm. And I guess my last question, what's the most frustrating about what you're seeing?
It's interesting. So my journey of training is I've treated all sorts of different cancers: colon, breast, thyroid, and then ultimately specialized in lung cancer as I went through my own training. When you have a conversation with someone about colon cancer, obviously you explain to them what's going on and what you can do for them and how to help them. But the amount of self-blame when a lung cancer patient comes to the doors, that I've done this to myself. And I think when we frame smoking as an addiction issue or a mental health issue, you realize how sad that is, that when people blame themselves for this disease, when really we need to be working on how to get them better and how to get past this. That I find the most heartbreaking. The other portion I would say is I had a patient come in last year and had two pieces of paper in the folder that was given to me. The first piece of paper was their discharge letter from lung cancer screening trial that they'd shown up and participated in the trial 10 years ago, but that they were told that it was no longer functioning because there was no program. And then the second piece of paper was a CT scan with metastatic lung cancer. And so this person had left the program 10 years ago. And if they'd stayed in it, the cancer would have been found. And by the time that they presented accidentally, it was too late. And that's like things of that nature are heartbreaking when you have that long view of it. So I think that you're right. And that's why I'm fully supportive of this forum, is that people need a voice and they need the opportunities. So.
Right. Okay, those are all really good points, and we'll take questions for you afterwards. I'd like to switch to Dr. Ambreen Sayani to talk about the inequities, because you actually are now studying the groups of people that are being left out of screening, or we're not being able to reach them. And I'm wondering what you're finding with your research and how you can drill down on that so that we can learn and get better at getting those who need help. Dr. Sayani?
Thank you, Avis. I was going to share some statistics, but you did that in a wonderful way up front. I do have other slides because we talk a lot about the statistics and the inequalities in lung cancer risk and outcomes. But what I really wanted to show today through those slides is what we mean by a socioeconomic gradient in lung cancer outcomes. So I'm going to share my screen, and won't take too long, but I always like visuals because they do better than words. Okay. I'm going to get through the first two slides because Avis, you did them. And it is really this slide where I want to start. And what it is mortality rates for lung cancer by neighborhood income in Canada. And we can see stats from the 1970s onwards to the year 2001, with the bottom graph with the diamonds being the richest quintile. I wonder if that was intentional or not, but in any case. And then we have the square bars, which is the poorest income quintile. And what we can see is that lung cancer risk and mortality has increased over the years, but that this burden of risk and mortality is not equally borne across the population. If you are living in the poorest income quintile, you are most certainly going to experience a greater risk of mortality. And this has persisted over time. So this difference, this socioeconomic gradient in lung cancer mortality is really the brunt of the focus of my work. I look at why does this exist? Why does it happen? And what can we do to reduce this mortality gap so that we have a more equitable disease distribution, access to care, and eventually more equitable health outcomes? To understand this better, we need to touch upon the concept of social location. And what is social location? It's a sociological concept, but what it means is it is the crux of where an individual lies in society based on the power, privilege, and prestige that they occupy on a hierarchically based society. So therefore, if you have more power, more privilege, more prestige, you're going to have access to more resources and be able to have better opportunities to take care of your health and eventually have a more fulfilling life with better outcomes. Let's look at this for lung cancer in specific. We do know that based on social location, individuals are more likely to be smoking. And we very often come across a term called clustering of disadvantage. So neighborhoods where there is immigrants, people living with lower income and precarious work, more housing precarity, you're going to find smoking is of a higher prevalence. Let's look at smoking cessation. It's the same statistics. Very rarely will you come across a smoker who hasn't tried to quit smoking. And I say this from my own years in clinical practice as well. They will always tell, oh, I tried to quit. However, it is those that are more resourced that are going to be successful at smoking cessation. Screening. And I know Dr. Finley touched upon some of those things, but then we look at individuals who are unable to take time off work, don't have the transportation, just specifically don't have the resources to be able to access the screening program. They're the ones that will be left out of a publicly funded program. And we see lung cancer incidence in those rates that I showed you. And eventually, because of the poorer access to treatment and delays in diagnosis, you have accumulation of risk over the life course and higher mortality. And I think this is just what I wanted to set the stage for in terms of what are the socioeconomic gradients and at which levels do we really need to work in a multi-pronged way in order to reduce the inequities that we see. And that's all that I wanted to share.
That's really interesting. The visual component there is important. When you look at the deaths between, say, the highest income and the poorer groups, Doctor, how many more deaths per hundred are there just based on economy, on the financial end of the patient's resources?
I would not be able to put a number to that. Dr. Finley, do you have a number to that? They're quite vast and they're quite different.
Yes, there's a 25% difference in survival for the same stage. And so 1 in 4 more people would die.
So that's even when they're picked up at the same stage of their cancer, they still have a 25% higher rate of dying, even though they're
Yes.
at the same level. Do you know why that would be? Nutritional status?
Well, do you want to go for it, Dr. Finley, or do you want
Oh,
me to? I
you
can.
take first swing. Yeah.
Sure. There are a number of reasons why individuals who are diagnosed at a similar stage would have higher mortality. There is a lot of theory that looks at immunosuppression because of chronic risk, chronic stress, and therefore the immune system just isn't working that well, increasing the chances of metastasis. We also have evidence to show that individuals living with less resources and living in socioeconomic deprivation will continue to smoke as a way to cope with the cancer diagnosis. Those are some of the things off the top of my head. Dr. Finley, would you want to add to that?
Yeah, I think that you're right. I think it's all the things that are working against them. I always sort of think that, in life, you're able to overcome one hurdle that's in your way. And depending upon um, your network of friends and family or your own comorbidities or your spouses, you can get over more and more. And that if you're on your own or if you have difficulty getting into appointments or you suffer from mental illness or addiction or any other problem, it just all stacks against you and ultimately results in either you don't get the best treatment because you can't get through it, you can't get to the appointments, or you just don't get there. So it's sort of a multi-hit phenomenon. When we drill down on how many get surgery, less of them get surgery, less of them have the best possible results, less of them get chemotherapy because they've got more comorbidities. So I think it's everything stacked against you, and it's on us to try to snowplow, to use a good Canadian analogy, things out of the way, and make it as easy as possible. And so when we have these navigators that we use to help people get through the diagnostic phase to treatment, and in particular when they're appropriate for the community they work in, they can do a great job of helping people where they're at and dealing with problems I didn't even know existed. So those are some of the successful mitigation strategies I've seen. And obviously a helpful family physician as well is irreplaceable.
Okay. Well,
I would.
sorry, go ahead,
Yeah,
Dr.
sorry, Avis, I just remembered one more. And we touched upon it earlier, was around the stigma associated with lung cancer. And I think that plays a huge factor when I do qualitative interviews with individuals, and they will tell you that the stigma and discrimination that they face in clinical encounters is often a huge barrier in terms of coming back for care and who they come back to for care. So the Peer Navigator programs, because they're so embedded within the community and actual lived experiences of patients, often do very well because they're able to connect over those bridges and hurdles.
We will talk a little bit about that later when we do some of the questions, but I'd like to go to Jackie Manthorn, who's in Ottawa now, and you have some issues because you're a very fierce advocate and a very powerful voice, I must say, over the years for patients. And one of the things you mentioned on the phone is that patients have a right to survive. They have a right to survive. You just have to help them get to that. So go ahead, Jackie, and talk about why inequity is an issue for you.
All right.
Okay, go ahead. I
Okay.
think we lost your audio there for a minute.
Yes,
Go ahead.
yes. You're very right. It is something that we're really concerned about. I was just on another call this morning where we were looking at how can we work to make sure more cancer patients survive the cancer. Could I have my next slide, please? And therefore, I decided to talk about lung cancer screening because, as Dr. Finley said, this is one way forward where we can hopefully diagnose patients earlier and therefore where treatments will probably work. As we know, we use CT scans, low dose CT scans during these programs, this screening. And there are already screening programs in Ontario, Quebec, and British Columbia. To date, only Ontario's has been made permanent, and there are important inequities in all three programs. Other than that, lung cancer screening is not available in the rest of Canada. Next slide, please. In Ontario, there was a pilot project and it was made into a permanent screening program. There are criteria for consideration. People can be referred by a healthcare professional, or they can self-refer. The problem is that there are only currently 4 sites where people can get lung cancer screening, and in the GTA, in Ottawa, Oshawa, and then only 1 up in Northern Ontario. And this is a major issue because Northern Ontario does not center around Sudbury. And so one of the things that the Canadian Cancer Survivor Network is doing this year is working on lung cancer screening. We want to, where there is screening, we want to see it expanded. Where there isn't screening, we want to see it created. So let's go on to the next slide. Quebec started their demonstration project last year. They have more sites, but however, again, they have 17 administrative regions in Quebec. So the province is not entirely covered. And again, we can see Montreal, Laval, Quebec City, the Gatineau, which is across from Ottawa, the South Shore of Montreal. They're all in larger urban areas, which is important. But again, most rural areas have been left out. So again, we will be looking at trying to make sure this becomes a permanent screening program and having it expand so it's accessible to everyone in the province. Again, the criteria are for people who are either still smoking or former smokers. And I'll refer to that later. British Columbia. This was announced in 2021. It's up and running. Again, there is an age criteria, and you must be a current or a former smoker and have smoked for 20 years or more. As far as we could find out, there's only 1 screening site at this point, and that's in Vancouver. And obviously, I don't need to talk about what gaps that leaves in a province the size of British Columbia. We are going to be working with other organizations, including the Lung Health Foundation, to try to get across the idea that it's really important to try to diagnose people earlier, where there is an opportunity to treat rather than later. But I wanted to refer to the 28% of never smokers who end up being diagnosed with lung cancer for various reasons, which Avis, you listed before. How do we find them? This includes some of the advocates who work with us and Lung Health Foundation, who are young, who are have no idea that they were at risk of lung cancer for whatever reason, and who do not necessarily do well. We know we have lost a few of them in the last 6 months. The newer treatments are able to keep people with advanced lung cancer alive for longer, but not forever, usually not for a normal lifespan. One of the advocates we work with is 8 years out from her diagnosis, and she calls herself a unicorn because she's unique. And she really is. And she's been involved with us in doing a lot of advocacy and awareness raising on with decision makers, especially in Ontario. I guess what I want to say is that we're at the beginning of the possibility with the screening programs to make a difference. And so this is something we'll be concentrating on going forward.
Yeah, thank you very much, Jackie. That's really important. You're right. There's a whole raft of patients coming forward that don't have any of those key risk factors. The question is, how do we do it? So I guess I'll open it up for discussion here in the sense that as a health reporter, I recall being on site at Mount Sinai Hospital with Dr. Heidi Roberts when they were doing the first CT scan studies to see if they could screen people out. And this is like a good 15 years ago. My question is, why is it taking so long to get screening in an organized fashion across the country? Anyone know why?
Well, I could hazard a guess that the fact that our healthcare system is fragmented, that each province and territory is responsible for delivery of its own healthcare, and that includes screening. So just because it's happening, I mean, we can use the fact that it's happening in 3 provinces to try and leverage new programs being developed in other provinces. But of course, the elephant in the room is the huge amount of money that has been spent on dealing with COVID. And that may slow things down. But I think that we can use the evidence gathered from the screening programs that already exist, including or especially the pilot project in Ontario, which has been going on for longer, to say, look, here's what happens when you can screen people.
Has
It
has
makes sense
anyone
to do
has
that, doesn't it?
anyone done an assessment to find out? So, in all the years that it hasn't been available, you've got all these patients, the 21,000 dying, 28,000 every year who have to go through treatment. The cost benefit of screening and moving that along quicker in terms of lives saved and fewer costs in terms of chemotherapy and radiation. Dr. Finley, anything on that?
I have a whole bunch of things to unpack. Let me think. So I'm the clinical lead for lung cancer screening in Ontario. So part of this sits under my portfolio for sure. And everything Jackie said, I think is true. And I want more yesterday. And I also, in my other role at CPAC, when we were putting it through this strategy 5 years ago, was advocating for lung cancer to get more resourced. And one of the things I'm most proud of is the fact that in the latest strategy, lung cancer screening is in CPAC's national strategy, and have put millions of dollars towards funding, getting these programs off the ground, and they funded every province to move forward. And so I think that there is room for optimism. COVID derailed a lot of everything. But we really were pushing that boulder almost over the top of the mountain to roll down the other side for lung cancer screening. And I think in the next year, we're going to see a lot of developments in that area. So I think there is room for optimism, but I'm impatient by nature. And I want to see it available for everyone, because I think that you're right that we've lost people that could have been saved, lots of people.
Yeah.
And not everyone's going to sign up for screening. We know that from breast cancer and colon cancer, that even when readily available to everyone, not everyone
There.
will get there. And so, and sort of my last point was, and for those that are disadvantaged or vulnerable, those are the people that you need to work twice as hard, but we need to do it because they'll get left behind, and they always do, whether it's a vaccine uptake or anything else. That when it's an equal playing field, the people who are vulnerable always lose out.
Yeah. So my question then, Dr. Sayani or maybe Jackie, is the bigger issue the availability of the screening, or is it that it's difficult to get the people at risk, most at risk there? Which one's the bigger problem?
Jackie, would you like to go or shall I?
I think they're both a problem. You can create screening programs in every health district in a province and then still find that not everyone is going for various reasons to get screened. And we can see that with COVID vaccinations, which are to keep people healthy or healthier if they get COVID. But it's a matter of, as I think that Ambreen, you said before, that people often are not able to go, or they don't know about it, or their literacy level is low. There are all kinds, or they have addiction issues, and no one else they know went. So I think that we have patient groups have a job to do to try and get the information out to patients once the screening programs exist.
And that brings us back to your work, Dr. Sani. One of the interesting things that you're focusing on, and it's really kind of like a new edge in medicine, is that it's patient-centered research. You're actually trying to look and talk to the people who are affected to figure out what works for them to bring them in to medical care and to screening. Can you tell us more about what kind of research you're doing and what kind of input they can give you and how that can help make screening and healthcare better?
Sure. And I'd probably start by saying that this program that was run out of Princess Margaret, the one that was started 15 years ago. So I was part of that from 2017. And if you look at the data of people who are actually enrolled and participating in the lung screening, it wouldn't surprise you that they were mostly well-educated, well-resourced white men. And which is perfectly fine if they're at risk. But what it means is that there's a whole segment of the population that's being left out. So part of my work, and this was done in partnership with Princess Margaret and St. Michael's Hospital, the research that we did was trying to reach out to individuals who are living with low income and seeing how could we recruit them into the program. And I tell you, it may seem as easy as picking up a phone call and telling people, we have this data about you and would you like to come in for a screening program? It is extremely difficult to contact people who have incomes below $30,000 a year. If you reach them by phone one time and you manage to get them in for a screen, it is almost impossible half the time to reach them for a second recall. And that is a huge issue in terms of how do you call people into a program? And then if you do call them into a program and you need to recall them, if they don't have access to a phone, well, then our whole system is set up to fail them just because they don't have that way to access lung cancer screening. So as a part of the follow-up from that work, I partner with patients who are experiencing marginalization by society. And I say it that way because no one chooses to live in low income, and certainly no one chooses to live precariously housed. These are not personal choices, even though sometimes they are portrayed as such. These are conditions that are created by society. So we need to work with people, meet them where they are, and understand, well, there is this lung screening program. What would make it of value to you? And why would it be of interest to you? And how can we make it more accessible? And that is the kind of work that I'm currently doing. I work on a project that is led by a panel of 4 patient partners. Jackie is part of the grant committee, but really the co-design work happens in partnership with patients who are least likely to be included in the program.
And what are they telling you? What do they need to feel like it's safe for them to go to a doctor and get tested? What are they telling you? Do you have any early evidence or data points on that?
I would love to get all 4 of the patient partners in a panel so they could tell you themselves. But I think a real key thing that they say is timing. It's all about the timing. So if I'm out of work or if I'm living on the street, don't talk to me about something that's preventative. And if I'm smoking, you need to understand my life journey and work with me to time the smoking cessation and make the program accessible. Very often, patients will find themselves in clinical encounters where they're stigmatized and have had fingers wagged at them for smoking and saying, well, you're still smoking. And that doesn't work. It really doesn't work. Not when you look at the inequitable distribution of smoking consumption in society. You look at the way cigarettes are mass advertised to specific audiences. The whole system is set up to create that discrimination. So let's not blame people for where they are. We need to meet them where they are and work to design what works best for them.
I think to jump on that, okay, I'm not muted. I was worried I was muted for a second. Yeah, I think that in some cases, in the lung cancer screening for Ottawa, for example, they set up a satellite site in a rural location, which has actually done a great job of getting in people who live in that community. And one of the challenges of lung cancer screening is making sure that they're read by experts in those scans, and so that they're read in Ottawa, but they're delivered closer to home. So I think that there's strategies that what's called a spoken hub model that can be used to leverage a big center's expertise to help a small center. That you're right that a lot of those barriers that people face in stigma in accessing care is a challenge in and of itself. And certainly I have a friend who works in cervical cancer in Haiti. And because of the challenges in getting people back in, they'll do one-stop shopping. So you'll come in, get your assessment and treatment all before you leave. And I think that there are models like that that can work in lung cancer where you just come in once, it's read before you leave, and you have a plan in place that can be used to mitigate some of the barriers. But I think some are a real challenge. You know, I used to work in Bella Coola, British Columbia, and people didn't want to leave the valley. They'd never left the valley in their whole lives. And how to mitigate in those circumstances is a whole bunch of different challenges. And certainly, you know, just to touch briefly on it, having members of the community that can advocate or partner with or travel with people goes a long way. So,
Right.
you know, I think we've got a lot of work to do, but those are some thoughts.
We're getting some questions from people who are watching in. One of them was something that you mentioned, Dr. Finlay, about the navigators. Would navigators help that in terms of being the outreach, and are they in place in all cancer centers or in academic ones?
Right. So there's a couple of things to unpack there. So navigation, diagnostic assessment pathways really came into being about 10 to 11 years ago in Ontario, and they utilize a navigator, and they can have different levels of training. And so in different disease sites, there are navigators, and they are utilized in different ways in most regions. The funding from those has been largely scaled back. And so I think that there is, the funding has been taken on by a lot of institutions. And so Brantford, which is a lower socioeconomic area I work in, the hospital pays for the navigator. And they also have First Nation, Inuit, Métis navigators in a lot of jurisdictions that I think go a long way to helping break down some of those barriers. But I can't say that they're available universally to everyone, but I do think they should be. And I think that they should be culturally appropriate for the communities they represent, and that can help a lot.
Do you think that would help, Jackie, if there were more navigators or someone that's interfacing with people on the front lines?
Definitely. We know there are also drug navigators in various institutions where they help people navigate, how am I going to access this particular treatment because I don't have any money or I don't have enough money. I wanted to go back to the whole issue of one-stop shopping, if you will. We know that in some rural areas that for breast cancer screening, they had mammography vans. And they went around. My mother, who lived in a small town in Nova Scotia, used to go every so many years. They'd remind her and she'd go, or they'd just make an announcement, put it up on the pole outside the post office, coming on such and such a date, make an appointment or show up. And there'd be women there waiting to get their mammograms. That's how she got screened. And make it easy for the people who need to have it easier than, for example, people who can take time off work. And that's another thing. A lot of the screening takes place only during the day, which is when people are working. So if you're not able to take time off, or if you must go to work or you might lose your job, you don't go. Earning some money to live is more important than getting screened at that particular time in your life. So the idea that you came up with, Dr. Finlay, of having a way to be screened without it being time consuming and several appointments and whatnot, I think is really important to reach people who aren't able to give the time.
That's it. Dr. Sani, is that something that you're also hearing from your patients that they need it easier? They need it more simplified. Would that help?
I have yet to, and there is some literature that talks about individuals who are living in marginalized conditions having fatalistic beliefs, not being interested in screening. And I have yet, in any of my research, to come across anyone who has that belief. Everybody's interested in screening. It's just about the timing and opportunity. So, any way that we can make it easier, more accessible, culturally safe, trauma informed, people will want to participate.
That's so it's a shift in thinking here from the actual structure to just making it easy. And that's why the patients and what they need is so important, and that yet they've been kind of left out of the equation, right?
Absolutely. Once you start to plug them in and first identify, well, I don't know everything in terms of the health system, but you know a lot in terms of what you need from the health system. And together we can come up with a solution that works for everybody. It really is that way of thinking.
Right. Some of the other questions from the audience, when we say that there are discrepancies based on income due to limited access to resources, have you been able to tease out how that compares in regards to health coverage? So if you have private insurance, does that get you quicker access to anything versus, just being under the public umbrella? Is that an issue at all?
Not in my to my understanding. I think it's readily accessible to everybody, albeit when you're wealthier, there are less barriers to taking time off work and all those things. But the insurance itself doesn't do anything.
Yeah.
Yeah.
Yeah,
I have the same experience. It's the other resources that support the ability to use the care that's available,
right.
which really matter.
So the universal system that we have in Canada is basically there for patients. It's getting the access, getting the timing. The one-stop shopping is amazing because that's worked in reducing the stress of women waiting for a mammogram and getting the clarification from ultrasound and getting the diagnosis quicker. One of the other questions from the audience was, are there other newer screening technologies aside from a CT scan, like say a blood test, that could be brought to people in the community as opposed to having them come in? Is that an option, or is that too early in the development phase?
Yeah, that's not prime time yet. There's certainly people exploring those, but nothing that would be applicable.
So CT scan is the right way. Dr. Finley, of the patients that come to you with a newly diagnosed lung cancer, what percentage have gone through screening?
Just a small fraction. I'm in Hamilton, so we don't have CT screening there. A large portion of people are found incidentally. So they go in for appendicitis and the CT scan catches a part of their lung and they see a lung cancer there or some other incidental finding. But true lung cancer screening, we don't have it in Hamilton, don't have access to it in Hamilton. And as I said, I've been an advocate for it since the day the study was published. And we can't, those patients don't have access. Like we can send them to Toronto, but even those that are very motivated, it's tough to get people to go all that way, drive 2 hours each way.
Yeah, that must be a bit frustrating that,
Oh,
the screening,
oh,
not having screening in Hamilton, which is a high smoking community, if I'm
yeah,
not.
we're the largest volume lung cancer center in Ontario and probably in Canada, and we don't have it. So and I'm in the system. I'm a clinical lead, and we don't have it. So yeah, I completely agree with what Jackie said. I think across the country. So it's also, I have an international lens. I sit on an international lung cancer group. I have a national lens, and I have a provincial, and I have my own institution. And I am pushing in on all of those forums because I think that this is something that just we need. It makes no sense to me that we would not be delivering this to patients. So I'm ever hopeful and ever an advocate.
Yeah. All right. Another one of the questions, are there any studies on lung cancer and newcomers to Canada? Is there a higher risk there? And are there cultural barriers and linguistic barriers that might make it more difficult? And is there a way supporting them? I guess that would fall to you, Dr. Sani, about people who are affected. I'm not sure. Is that
I see
I have a
Dr.
bit.
Finley's unmuted. You can go for it.
I have a bit of information. Do you want to go first, or do you want me to go first? Okay. So one is data, right? So it's difficult sometimes to find everybody. We looked at it when we did that equities report for CPAC. We included recent immigration because that's the one group that we can track, and didn't seem to show any increased risk in that group. But because we have a very interesting immigration system in Canada, most people who are immigrants are highly educated, wealthier people. And so there's so many confounders that I don't think it's a fair representation of the group. And so one of the key aspects is trying to get better data that people want in the future that represents groups more effectively, because we don't actually do a good job in Canada. To do this report, we had to tie people's income tax all the way back to their health records, which was a lot of work and required, Stats Canada to help us in the back end. So I would say that we have imperfect data, but the data that we do have would suggest that's not the first group that we need to focus on.
Got it. One of the things that Jackie, I think you said to me on the phone was that you would like to double 5-year survival by 2025. Was that something we discussed?
No, maybe you discussed it with.
With one of the other ones. Okay. Well, is that a realistic goal? Can we double 5-year survival?
With screening across the country.
Yeah.
I honestly think that it will make a huge difference.
Yeah. It really would. And we've got newer drugs and other innovations, but in terms of singular undertakings, that is the one.
Yeah. So even because we discussed that with breast cancer, it's possible that the survival is because of the medications and the therapies. But you're saying that with lung cancer, it's the early screening that's the most important at this point.
Yeah. They're totally different diseases. Like lung cancer is really lethal, and breast cancer is obviously very serious and can be lethal, but it's got a longer period when you can do something about it.
Yeah.
Rather than lung cancer, when the window of opportunity is much smaller, and that once it's metastatic, we didn't up until now have particularly good drugs, and certainly not oral drugs. So people would have to take cisplatin-based chemotherapy, which is the classic horrible chemotherapy. And now we have new immunotherapies for a large portion of people, which can do sort of miraculous things. When you're talking about, Jackie, about a friend that was out 8 years, I have a guy who's a bodybuilder who showed up with metastatic lung cancer, a young guy, found a great targeted drug, and he was back in bodybuilding competitions. And it was, with metastatic lung cancer, and it was, he'd come in and looked like he could throw me around the examining room. And so it was fantastic every time I see him.
That's wonderful. That's a good
That is
story.
good.
That's a happy story. That's a good one. Well, it sort of leads to the idea, a young person with metastatic lung cancer, we're talking about probably smoking as being a risk factor there. Not sure. But one of the questions from the audience is about prevention. Okay, so we can improve on screening. How do we go even back further in this? And I see Dr. Sani nodding. I mean, how do we work on preventing these groups that are at high risk of smoking from starting in the first place? And are we doing enough? Or is there a way of pushing how to quit faster and better so that they are not chronic smokers? Dr. Sani, do you want to try that?
Yeah, sure. So I don't think there's any one solution to this. It's always going to be a multi-pronged approach, and we need to work downstream as much as midstream and upstream. And when I say all those streams, what I mean is if you have nicotine patches available that work very effectively, you want to be using them anytime that you can. When you have lung screening as an opportunity to detect early stage cancer, you want to use it every opportunity you have. But you also need to work upstream, and that means working on the policies that are creating the living and working conditions that are either supporting the initiation of smoking or the ability to quit smoking. So if there are people who are working precarious jobs and are experiencing homelessness, this is a we have lots of statistics that point to the clustering of smoking in these groups. And what you can't do is just distribute nicotine patches in a homeless shelter and say, well, we've got a problem solved here, because that will never work on its own. It can only be effective if you're also supporting people to live in safe homes with reasonable income in their pocket to live a reasonable life. So we need to put all of those things together. A bit of move in every direction is where we're going to see the wheels turning on this.
Okay, Jackie, your thoughts on this?
I agree totally. I think that we might say, well, let's try and make sure that people don't start smoking, but it's not so easy. And once they are smoking, stopping smoking is in those populations which are wondering where they're going to be living tomorrow night, or can't keep or don't have a steady job, or have a job which doesn't pay enough for various reasons for them to be able to support themselves. Well, their priority is not to stop smoking. I think that's very, very clear. Maybe for some of them, but not for the vast majority. And I think that if we don't tackle the societal problems that cause homelessness and food insecurity and job insecurity, then we're not going to reduce the numbers.
Yeah, I think that you also have to. Oh, sorry, Jackie.
No, there's no easy way.
I think we just got to take every opportunity. So we have a policy now that every time somebody checks in to our lung institute, they're asked their name and their birth date and everything else. And then the question that they're also asked is, "Are you a current smoker? Would you like help quitting?" That is a question, a universal question every time we have a touch point with healthcare in this institution. And we just got to take every opportunity, whether it's and not in a finger wagging sort of way. You're there to help them. You're part of their team, but you take the opportunities you can, and it has to be universally available and accessible. And that's not true everywhere.
I'd like to put in sort of a personal note. I think they have to work harder in elementary schools and in high
Yeah.
schools, because someone in my family, one of my children, despite me doing health for 30, 40 years, health journalism, and talking about having been in surgeries, watching doctors, thoracic surgeons pull out lungs of smokers and showing us what they saw. He still picked up smoking in high school, and it's been impossible to get him to quit. Impossible, because you're young, you're stressed, you're trying to work. He now has a family. And, I think of it as a parental failure in a way, because I had the messaging, but the school and the environment there promoted it, and it makes it difficult. And cheap cigarettes are so easily available. So that's super, super difficult. And I don't know what we do, but I would love to see more done at the young person's level, to see if we can stop it there, because it seems to start and then it carries through the lifespan. So
I think for me, when someone's in that situation where they've started smoking and it is a really strong addiction, I can tell you I'm a former smoker, haven't smoked for many years. The last time I quit, which says how many times I might have tried, I said, I'm not going to remember when I'm quitting this time, and I really don't. I can't even tell you the year. But I think the only thing that you can do with someone in that situation is to say, I wish you weren't smoking, but you'll quit in your own time, because it's no point making someone feel guilty. I have a daughter who smokes.
There are thoracic surgeons who smoke. It's interesting. Like I've had partners who their whole job is to take out lung cancer, and they smoke. That speaks to the addiction to me.
yeah, I wonder, is there something we should be doing at a bigger level on this? Like,
It's interesting. So at CPAC at this federal level, almost everything has a smoking cessation in it somewhere. But you're right. It's at those really high levels. It doesn't seem to trickle down. It's those very personal interactions and those sort of communities and your social circles. And actually, one of the great challenges right now is vaping too. Like the young people have taken up vaping with all abandoned, and we have no idea what the long-term consequences of that is. So
yeah.
it's
It's a big issue. Well, we're coming towards the end of our session. I mean, one of the key things I think that I'm taking out is the idea of the one-stop shopping. So that would make connecting with the patients and the screening come together so that it all happens at once. But as we wrap up, I asked each of you as we were prepping for this, if you had one key message, a take-home message that you want those watching and those who will be watching online because this is being recorded, what your message is. Uh, what would you say? Let's start with you, Jackie. What is the take-home message you want people across Canada to hear?
Every one of us who's concerned about this issue should be pushing for screening right across the country. That makes it available to everyone at risk. And eventually, people who think they might be at risk. We don't know how many people have been exposed to radon. When people find out, what do they do?
Should they be able to ask for a scan?
Yeah, yes,
You would like anyone, because if air pollution is in fact a risk factor, they should be able to ask for a CT scan just to make sure, right?
yes, we don't want it overused. I mean, I remember when in an earlier career, I was teaching back in the days where they made every teacher have a chest x-ray every September. Don't want this was in Nova Scotia, and that's what they asked. And one might wonder how many breast cancers developed in teachers from that.
But so your message is your campaign this year, your focus will be screening.
Yes,
Screening, screening, screening.
yes.
Good. Dr. Siani, what is your key message to the take-home message?
My key message would be that lung cancer screening is extremely important, but if we don't take an equity-oriented approach, then we're going to be missing out on the populations that need it the most and can benefit the most. So we need to bake in equity from the word get-go. When we say lung cancer, risk, treatment, mortality, we need to be thinking equity right up front and the social distribution of disease. That's the only way we're going to think in the right direction and come up with the right solutions.
And you said to me you want people to change the way they think. And that's the message.
That's the message, that we need to stop the focus being on individuals and you need to quit smoking, you need to come for screening, you need to come for treatment. We need to shift that focus in terms of what can we do as a system and what can we do in terms of a society in order to reduce the risk and increase access.
Okay. And Dr. Finlay in Australia, what is your key take-home message? What do you want Canadians to know?
I think that the other two speakers have really framed what I think is the value, which is equitable lung cancer screening available to all. But I think the other thing I would say is just don't forget about this tomorrow, because I think that is the problem is that in a life when there's so many competing needs, we forget about things. So this is a value, and we need to focus on it.
Right. Well, certainly COVID's pushed everything aside. And I think now people can start thinking about, I mean, we know there's a delay in diagnosis and treatment for a lot of different diseases and cancers. So you can see hopefully there'll be a bit of a shift back to normal because these are treatable, often treatable, survivable conditions. And so if people are diagnosed early, this would be so much better. All right, well, our time is almost up. I just want to thank all of you. Your perspective is so important. And this is such an important issue because I can only imagine how much our healthcare system, it would be so much lighter if we didn't have the burden of lung cancer and even, all the smoking related diseases. It'd be huge. So even if we can move the bar a little earlier to more screening so that you can catch people early, there's a cost savings to the health system. There's a cost saving to lives. There's a cost saving to the whole country and families who are affected. So I want to thank you all. I look forward to seeing Dr. Siani's research on patient-centered research because I think that's the future. And I'd like to thank Jessica Sofer, who's been in the background. She's our little angel who's been doing the slides and doing all the switching. and thank everyone who's been listening in to this policy forum from the Health Foundation. And we also are thanking the sponsors, Merck and Janssen Pharmaceuticals, for sponsoring this session. There'll be another discussion, another policy forum next week, looking at therapies and how to deal with some white paper discussions on that. And I hope you can join us all for that. In the meantime, thank you so much, Jackie and Dr. Sandy and Dr. Finley. You can go back to your scuba diving. All